Good morning. When we talk about bifurcation, what is written here for left main, can I have a pointer? Holds true for most of the bifurcations. As we see, the angle between the two vessels is very important. The atheroma burden at the site of bifurcation is important. And of course, the diameter of the two vessels coming out of bifurcation is also very important. So when we, I'm looking for a pointer, if somebody can get me a pointer. When we talk of stenting the bifurcation, we talk of the one stent, that is the main branch stenting, and and the T-stenting, of course. Then we have culottes, we have stent crush, and we have kissing stent. All these techniques, as we all know, has their own good and bad, and we have to learn to use them very effectively. When we talk of kissing stent, this is actually a very simple technique. Those who are learning bifurcation will find it very easy. But let me tell you, if you want to recross for some other reason later, it's going to be a big problem. So always when you do a kiss for a stent, do a perfect job before you come out. Sometimes it's even hard to get another balloon for post-dilatation in. So always be very careful about kissing stent. It may look simple, but the results of kissing stent, SKS as we call it, are good only in certain people's practice. The crush as well as culotte, the huge advantage is that you will never miss the intima. That means the metal coverage is absolutely perfect. However, recross once the stent is deployed sometimes can be an issue, but generally one could get it with good amount of experience. So if you want to really be perfect on the intima coverage, the angle between the two vessels is not going to be very wide. This becomes a very important technique. And T-stents, of course, I really follow T-stents wherever possible, because you don't really overlap too much metal and you can come out with good results too. So when you talk of crush versus culottes, the culottes actually appears to be a slightly better technique. Personally, I would favor culottes over crush in most of our cases, and the event rate following culottes is much better. This slide is fibrillating, not the patient, but here you have aneurysm and a critical disease, so we put a stent in this segment, preserve the diagonal branch, which is a very good branch, and then put a covered stent in the proximal portion. So this was a kind of defining technique, and the patient comes back 9 months later with the instant restenosis just at the proximal portion of the covered stent. The distal stent, the side branch is flowing very well. However, the bifurcation re-narrowing has expanded acutely into the circumflex. So here we have put a stent in the circumflex first, remove everything including the wire, do a balloon dilatation with a big size balloon to sort of flatten out the tips which are projecting backwards, put another stent, and as always end up with a kiss. So this is the final result on this particular patient. It's about 2 years. Patient continues to do very well. So when do you do kiss technique, SKS technique? Now here is a potential scene where you have a reasonably narrow angle between the LAD and the circumflex. LAD is showing critical disease, and you start with SKS technique after pre-dilatation. Important thing to remember is the two markers at the proximal stent must match each other. If one is ahead of the other, you will never ever get a good results. So my personal feeling is when you inflate these two stents, go up together to say something like 6 or 8 atmosphere, then go desynchronous, like go 12 on one and 4 on one, and again reverse it, and finally again with 8-8 and 6-6 and come out. So you must learn to finish the inflection then and there, assuming that you may or may not be able to take another non-compliant balloon in at the end of the deployment. This is the result on this particular case. So when we talk of left main and bifurcation, and we say one stent or two stents, this is what the statistic says. One stent probably has a lesser event rate in syntax. This is another study again highlighting that one stent is better than two stents. And this is actually a study of 1111 number of cases. And here, one stent is closer to shaft and ostial lesions, while two stents clearly inferior to shaft and ostial lesions. So again, in left main, it appears that whenever possible, treat bifurcation lesions with one stent. This is what the literature states, but I'm personally in left main bifurcation situation almost always a two stent man. This is a scene where you have a critical lesion in the ramus, but this ramus was so huge, it was far bigger than diagonal, and the ramus diameter actually matches the left main diameter better than the LAD diameter. So we had first stent deployed from left main to ramus, and then through that the second stent was deployed to get this kind of result. Patient doing very well during follow-up. This is an even more challenging anatomy. We have actually very dominant circumflex, as you can see, this is a very dominant circumflex. You have trifurcation. I think the lights are coming right on the screen probably because the images here are very good. However, what we are trying to show is you have this is the acute angle left main. So the first stent was put from left main to circumflex. Second stent was put in the ramus, and the third stent was put in the LAD, ending up with KISS every time with this kind of result. And 8 months follow-up angiogram clearly shows that this was a very, very good technique to follow. In left main bifurcation situation, personally, I'm always a two-stent man, and this particular case actually took 3 stents. This was again a scene where circumflex is a dominant vessel. The origin shows narrowing. Stress test thallium was positive only in the circumflex territory. LAD was not showing inducible ischemia. However, you can see some disease in this portion. So if you put a stent, single stent, as we say many times, from left main to circumflex, I'm not somebody who would take chances on LAD of this nature. So we sort of pre-decide that this patient would go in for 2 stents. So this is an LAD stent deployed, circumflex balloon protecting the back end of the stent so that our next stent can go in easily. Again here, the circumflex diameter is matching the LAD diameter better. So once you do that, you bring in a left main to circumflex stent, a big diameter stent, KISS, and this is the final result that you would get. I would be very, very scared to leave LAD unaddressed if you're going to end up with one stent in this kind of situation. You can actually see the extent of circumflex. It's supplying a huge territory. So if you go back to the data, still it continues to show, like in research and T-search, again, the MACE result looks comparable between 1 and 2 stents, but TVR better with 1 stent compared to 2 stents. Again, in this case, left main bifurcation, 1 stent better than 2 stents. So on a whole, left main data appears reasonably in favor of single stent. We are into SJ Park's left main registry, and our last 51 odd cases, all stented with 2 stents followed up for more than 7 months, all have no issues at all. Whatever we talked about left main bifurcation, to some extent hold true for other bifurcations too. This is a comparison between provisional on one side and 2 stents on the other side. The death is probably same, myocardial infarction slightly more in provisional, the TLR probably neutral, and stent thrombosis again more in provisional. So on a whole, it appears not a bad idea to do 2 stents if you think the vessel is going to be quite large. Here in this case, you can actually have 3 important vessels coming here, the LAD, the D2, and the D1. So if you see the extent of the vessel, D2 especially, D2 appears to run all the way to the apex, probably more important than the LAD. So here in this case, we dilate the D2, don't dilate the LAD at this stage, put a stent in D2. There is a pinching of LAD which is expected, come in with another stent in LAD, and then do POBA to the pinched D1 here, and ending up with the result of 2 stents in LAD D2, you can call it parallel LAD, and another balloon to open up the pinch D1 side branch. Again, patients follow up showing a remarkable steadiness. This is again another case, this question comes to our mind many times, which one to stent, which is the main branch and which is the side branch. Here again, you have D branch running all the way, a very healthy vessel going here, while in contrast you have LAD which is quite diseased, stopping short, kind of type 2 LAD, and we decide to treat the diagonal as the main vessel, and the stent going from proximal LADs into diagonal, and just preserve the flow into diagonal. It's not that we are averse to single stent, but you have to choose which are going to be your single stent cases. Also sometimes the angle at which the branch, the side branch is originating will take your decision as to which one is main vessel and which one is the side branch. Here is in this case, you can see the tightest portion is the side branch here. And you will have to sort of, if you put a stent from circumflex into the upper OM, you would find it very difficult to get back into this lower OM because it's sort of looking up, has a critical disease, and so on. So here our stent strategy would be to stent from proximal circumflex into distal OM, and then treat this as a side branch, though this appears to be a bigger vessel than this particular vessel. So always access to the side branch has to be simple. If you think access is going to be an issue, always stent the side branch first and then forget the provisional stenting in that case. So it's very important to sort of think before you start bifurcation stenting. So very difficult access, stent the side branch first, and if you have a wide angle, consider T-stenting, if not single stent. And what about final kiss? Almost a necessity. This is a comparison between no kiss and final kiss. So whenever you're using a more complex technique like crush technique, you would find that there's a bigger difference. So always end up with a kiss. Even if you're using a single stent and just opening up the side branch with a balloon, as long as the balloon is going to be more than 2.5 in size, 2.5 and above, always use a kiss primarily because if you dilate only the side branch with a single balloon, you're likely to disturb the polymer of the stent in the main branch, and the patient could have issues with the main branch which you never want to have. So always use techniques like stent boost in this case, one stent deployed, second stent getting a finer position and ending up with a final kiss. What about drug-eluting balloon? A very important option. You put a stent, dilate the side branch with a balloon, but if you think it is sizable, reasonably important, has some kind of disease, I think end up with a drug balloon on the side branch. In this case, you can see the diagonal side branch is important. The LAD is actually a reasonable sized vessel with some kind of disease in that area. But here, not to hurt the LAD, we just do balloon drug to the side branch. So this could be a very effective strategy too. So this is a case where you have a LAD which is showing a significant disease, but look at the diagonal side branch, very big size, but disease just at the mouth, and here we prefer to take the dedicated bifurcation stent. Most of you know that it has a small side arm, so we have 8 millimeters of stent beyond the origin of diagonal, 2 millimeters of stent projecting into diagonal just to keep it open, and this is the kind of result that we have on diagonal, just single stent, but keeping the diagonal fully open. So this is the Nile pack stent with this kind of technology where you can have the diagonal fully open. So to conclude, when we talk of one stent versus two stents, when you're planning one stent approach, make sure that the jailing of the side branch could be an issue. There could be a difficulty in rewiring. So always take into account how important is the side branch, how easily you can wire it, and how easily you can take your balloon and subsequent stent in case if there is a problem. Many of us don't like to balloon the side branch because of possibility of dissection, and when you want to rewire, your wire will keep getting into the dissected segment. So complete the main branch first, then you cross and then dilate the side branch whenever you are doing a provisional stenting. If you have a vessel size which is less than 2 millimeters, just ignore it, don't worry too much. You may put a side branch wire just to maintain the flow. Mind you, loss of side branch on table can lead to a CKMB leak, and CKMB leak is correlated with the long-term mortality and long-term MACE. So always avoid loss of vessel. It doesn't necessarily mean that you have to perfect the mouth of the side branch. And if you have a vessel which is more than 2.75, I think you should always try and preserve it. So whenever you talk of provisional stenting, it remains gold standard. Large side branches with osteal disease extending to more than 5 millimeters, likely to need 2 stents. And side branches whose access is going to be particularly challenging should be secured first, preferably with a stent. And a small invitation to you all for my meeting in Pune. This is the Asia Intervention Summit last year. Ruby Hall and CAT together organized this meeting. The dates are September 21, 22, 23. Please do remain in touch with us and come to Pune. Thank you indeed for your attention.
Thank you, Dr. Hiremath. That was a very nice presentation. We have instruction that there is a live transmission from